Thank you all for joining us for the second session of the MLD Standards of Care meeting series presented by Cure MLD. For those who don't know, Cure MLD is a global patient advocacy organization dedicated to helping families impacted by MLD, metachromatic leukodystrophy. And we are really excited and delighted to have you all here today to go over updates in MLD newborn screening, and hope that this information will inspire further collaboration. For rare diseases like MLD, collaboration and even international collaboration is crucial, as it can advance the field faster. We are excited to be hearing about the new pilot program in New York called ScreenPlus, as well as learning more about how states will follow up with the ScreenPlus families. Also, we'll examine the role that advocacy groups play in furthering and expanding newborn screening for leukodystrophies here in the US as well as worldwide. So let me introduce you myself, for those who don't know me. My name is Jaap-Jan Boelens, and I'm from Memorial Sloan Kettering Cancer Center. I'm a pediatric oncologist and immunologist specialized in transplantation for cell and gene therapy. I'm the chief of transplant for the pediatric and young adult program, and I was trained in Europe and came to New York City to become the new chief of transplant in 2018. And what is my connection with MLD? Well, I started and built a transplantation program for inherited metabolic diseases about 15 years ago in Utrecht, the Netherlands. And this includes not only leukodystrophies, but also MPS diseases. And we were the centralized hospital in Utrecht in the Netherlands. And we got the referrals from whole the Netherlands, but also surrounding countries, as well as from smaller countries in Europe, Middle East, India, Iran. And these families, because we didn't only have a transplant program, but also a long-term multidisciplinary follow-up program, because this is also crucial. And we will talk about that later today as well, because the intervention is one thing, but a multidisciplinary follow-up is crucial as well. In addition to building this program, I was also involved in multiple transatlantic collaborative studies for MPS as well as leukodystrophy diseases after cell therapies, bone marrow transplantation and gene therapy. And I was also involved in gene therapy trials in Europe and now in the US. And I was involved in advisory boards for newborn screening in Europe. So, and I'm really delighted to be the moderator of this session today. Before I'm introducing to you the three speakers of today, a couple of housekeeping items. Please be sure to jot down your various questions as you think of them. And we will have time by the end to go over this with an Q&A session. We will be recording this session, and this will be made available after the session. So, and with this, I'm really happy and delighted to introduce to you the speakers for today. If the slides drive. First speaker will be Dr. Melissa Wasserstein, Montefiore Medical Center. She's going to talk about the ScreenPlus program. Amy Gaviglio, she's a consultant and genetic counselor. And finally, from the families and patients perspective, from QMLD, Shanna Quimby. And the agenda for today, first, we will start with 10-minute presentations for each of the speakers on the various topics on the screen. So New York ScreenPlus pilot, the New York's newborn screening program counseling and follow-up by Amy Gaviglio, and Shanna will speak about newborn screening for leukodystrophies as a whole. After that, I will moderate about 40 to 50 minutes to go over a couple of moderated questions. And after that, we will have time for about half an hour to go over the questions from the audience. And with this, I'm happy to introduce to you Melissa Wasserstein from Montefiore Medical Center and Albert Einstein, let's say college. And she is going to talk about and share data with you about the ScreenPlus program. Melissa, take it away.
Thank you, JJ. Just make sure I might need help advancing. I don't know if it's been signed over to me. Thank you. So good morning, everybody. I am delighted to share with you information about ScreenPlus, which is a multi-disorder pilot newborn screening program. So the overarching goals of ScreenPlus are to evaluate how well newborn screening is working, including the analytic and clinical validity of the screening assays, determine what it looks like in terms of when to refer a child, and also to define the disease incidence in an ethnically diverse population. That's the first piece. The second piece is to determine how well newborn screening is impacting phenotype of babies found to be affected through longitudinal follow-up of true positive infants. And the final aim is to examine the ethical, legal, and social issues associated with screening newborns for complex disorders. It's a complicated infrastructure for the program with funding from NIH, as an NIH grant, as well as funding from industry and advocacy partners. And the hope is that once we have a lot of objective data, we can use that information to then help support RUSP applications for the various disorders on our panel. Next slide, please. Our pilot hospitals are shown here. We're doing this study in New York, and we have chosen specifically very high birth rate hospitals that are in ethnically diverse regions. And this slide shows the estimated annual births, how many births we're expected to have over 5 years of screening, and then what it might look like if we have a 73% consent and uptake rate. And that 73% consent rate is based on a previous pilot study that we did for lysosomal storage disorders in New York, where a total of all the babies born in those hospitals over the 5-year period, 73% of the families agreed to participate. Our informed consent, again, this is a research study, so we are approaching families and asking if they want to participate. We're using an e-consent type model, estimated to take about 10 minutes per encounter, which is similar to what we did in our previous study where we used a verbal consenting model. Anybody has ever done any research projects? It's often a bear to get them through IRBs, so we've tried to streamline things and are using a single IRB for all of our sites. Once parents agree to participate, they automatically get emailed information, a copy of the consent, a copy of the brochure, links to our website, etc. So we have, as I mentioned, it's a multi-disorder pilot newborn screening program, and we have, to start, 14 disorders on our panel, including, of course, metachromatic leukodystrophy. Importantly, our panel is fluid, so if there is a disorder that's perhaps added to the RUSP during our 5 years of screening, we can remove it. And we have already been approached to include several other disorders that we might be doing in the second year of the study, as long as they meet our criteria for inclusion. And those criteria to be included on the ScreenPlus panel include having a dried blood spot screening assay that can be multiplexed, high throughput, reasonably priced, and has already had positive baseline validation studies. We want disorders that have significant morbidity or mortality if they're not treated. They have to have a pediatric phenotype. Many of these disorders have a very broad spectrum of severity, ranging from severe early onset to milder, perhaps even adult onset. So we don't want to pigeonhole ourselves into one form, so we just want to make sure that there's at least one form that does present during childhood. And the last piece is that there has to be either an FDA approved treatment or treatments currently in trial. And the disorders as shown on the right include S-acetylcholinesterase deficiency or Niemann-Pick AB, CLN2, which is a type of Batten disease, cerebrotendinous xanthomatosis, Gaucher disease, Fabry disease, lysosomal acid lipase deficiency, MLD, and then the MPS disorders 2, 3B, 4A, 6, 7, and Niemann-Pick C. So another important feature of ScreenPlus is that we want to make sure that the screening assays are as accurate as they can be. So we are using multi-tiers of screening. This will all happen at the newborn screening laboratory prior to call-out, so that we can try to really reduce the number of false positives. Perhaps even using this method, we can help predict phenotypic severity. And for MLD, the first tier is we're measuring sulfatides in the dried blood spots. If the sulfatides are elevated, the next step is to measure the aryl sulfatase A activity in the dried blood spots, as well as DNA testing, where we're going to look at the for variants in the MLD gene. And it's important to acknowledge Michael Gelb, who developed the assay, and Joe Orsini, who is running the leader of the newborn screening laboratory, performing the assays for us. So our ScreenPlus reporting system is it's integrated into the New York State reporting system for routine newborn screening. So if the baby is positive, they will be reported out to the ScreenPlus geneticist at each of our sites, because most of these sites are already receiving kids with, for example, PKU and other routine newborn screening disorders. If the results are normal, then they're going to be shared with via the health commerce system, so they're available to the baby's pediatrician. So positive results will be reported out, and babies will be called in for evaluation, and negative results will also be available to the family. The routine newborn screening results in New York are typically reported out between 3 and 7 days. This is going to be a little bit slower, but we're hoping to have all results out between 21 and 28 days. Next slide, please. Thank you. So as part of it, again, our second aim was to see the impact of newborn screening on long-term outcomes. So we're establishing standardized follow-up protocols for each disorder. So that when one of our babies is positive and the doctor sees them, they will have some information about what to do and how to proceed with that. So these algorithms are including guidelines for treatment referral or access to clinical trials, and they're all being developed with help from our expert advisory boards. And the MLD advisory board is shown on the bottom, and Laura Adang, JJ, who's moderating today, Maria Escalar, Heather Lau, Eric Melick, and I'm sure a lot of you know those people, and they have been very kind to lend their time and expertise to helping us develop these guidelines. And importantly, they've also all offered to see the babies. So if there are docs in New York that are feeling, that maybe MLD is not their area of expertise, we can absolutely refer and make sure that the babies get the best possible care. So our rough guidelines for what to do with a baby who's either positive or uncertain for MLD is to do some baseline evaluations and then see them roughly every 4 months to do additional evaluations to see if the disease is progressing and if and when they do need referral for transplant or for clinical trial. Thank you. Okay, as another part of our study, as I mentioned, the first slide is to do some ethical, legal, and social assessments of how, what it's like to have newborn screening for complex disorders and some disorders that may not present until adulthood. So we're working with Aaron Goldenberg, who's an expert pediatric bioethicist, and basically every family that consents to participate will be offered the opportunity to participate in these Llc surveys. First one will be done at the time of consent. We're going to ask about if they approved of how we educated them, if we can do anything to make things better, if we can do anything to optimize their education about it. Babies who are positive are going to go into one arm, and we're going to be evaluating how that positive screen impacted the family in terms of stress and anxiety. We're going to be doing some interviews later on to again learn how we can better support these families who have had a positive newborn screen. Babies who are negative, which is going to be the bulk of children who participate in the program, will a whole different type of questions that we're going to be asking them about their impressions about expanded newborn screening, about later onset phenotypes, about future newborn screening and genomics in newborn screening, etc. So we're hopefully going to have thousands and thousands of parents who are willing to share their opinions and their experiences with newborn screening, and that will help us ultimately really kind of hopefully improve and optimize the process. Next slide, please. Thank you. The problem why I'm having trouble advancing the slides is I can only do it from the slides, and it's a white arrow on a white slide. So that's why I'm asking for help. So thank you. And then for my last slide here, here's a shout out to Maria and Al, who we met last week or a couple of weeks ago at the last session that we had. And this is focused on interviewing families who are confirmed to have a ScreenPlus disorder. We know that we really barely study parents as part of newborn screening. Parents who, the focus is always on the children, and in my experience through many, many years of diagnosing children through newborn screening is that the parents tend to be very traumatized and probably could use a lot more help than we are currently giving them. So the focus of this initial phase, with Maria doing most of the interviews, will be to interview parents to learn about experiences with a positive diagnosis and how the medical community can better support their needs. And then as part of our program, we're just so delighted to have Dr. Al helping us to offer non-research confidential support for parents. So he'll be sponsored by the Cure MLD Foundation. They're going to be supporting up to 2 counseling sessions per newly diagnosed ScreenPlus family. You've all met Dr. Al last week, and I'm sure you all can see what a massive benefit this might be. This is again non-research, so whatever the family talks to them, we're not collecting, we're not analyzing, we won't even know about it. So it's nice and secure for them. Okay, next slide, please. Thank you. Our timeline, we got our notice of award from the NIH back in September 2019. We had hoped to start screening within several months later, but obviously COVID got in the way of everything, of every aspect of the study. So we are now actually really looking very closely. I'm thinking it's just at this point a few weeks away where we are submitting the final validation studies for the ScreenPlus assays, a final little amendment to the IRB. We've hired our first on-site recruiter here at Weiler, which is the hospital at the Bronx. And we're hoping to get that first baby in the next few weeks. And then we're going to expand and get all the other pilot hospitals up and running. And the next slide, please. Thank you. And this is a massive team. I have our community advisory board shown here, which we had a meeting, I guess it was last week. Maria's little face is up there somewhere, as a Dean Serb is also part of the MLD community. So thank you for your attention. I'm happy to answer questions later on.
Thank you so much for this nice overview and great overview. Next speaker, Amy Gaviglio. As mentioned, she is a consultant and genetic counselor, and she will mainly talk about follow-up. Amy, floor is yours.
Excellent. Can you hear me okay? All right. Well, thank you so much for the opportunity to talk with you today about the newborn screening system and the very important role of counseling and follow-up. So let me see if I can do the slides by myself. Here we go. All right, so I really like to start with this slide to set the tone of how crucial collaboration is in newborn screening, certainly in general, but particularly ensuring that the downstream experience of the newborn screening process on the family is really thoughtfully considered, planned for, and ultimately implemented. When many of us think about newborn screening, we think of it as a test. But it's really important for us to shift this mindset and realize that successful newborn screening really does require a system approach, starting from the collection and transport of the specimen, of course, the testing or analytical phase of the specimen within the public health laboratory, and then the subsequent notification of families and clinicians of any actionable results. And of course, spanning all parts of this process, there is a need for robust and appropriate communication between all the key players. So for the purpose of my time, I will be focusing on these two components. So the education, training, and communication, as well as the follow-up or what we call the post-analytical piece. Next slide. Perfect. Thank you. The reason why communication and follow-up is really so important in newborn screening lies in really the nature of what a screening test is. So for newborn screening, we're taking a seemingly healthy population of newborns, and we're using screening tests to filter out those babies that are likely to have disease, so those in orange, those that are high risk, from those that are unlikely to have disease, or those that are green or low risk. And so because this is just a screening test, those found to be high risk, so again, those orange babies, need further testing, which we call diagnostic testing and evaluation, to determine if they are truly affected, so a true positive result, or if they are actually unaffected, or what we consider a false positive result. Next slide, please. See if I can do, okay. Luckily, newborn screening programs have really evolved over time to now having staff dedicated to monitoring those high-risk results. And these staff are really charged with, one, of course, notifying typically the primary care provider of the result, and then helping to make the connection between the primary care provider, the family, and an appropriate specialist. Follow-up staff then do work with the specialist, typically, to obtain results from the diagnostic testing. That allows the newborn screening program then to ultimately categorize the case as a true or false positive, as we talked about kind of on the previous slide. All newborn screening programs vary slightly in almost every way, and this is true of their follow-up approach as well. So there are some cases, some programs do have the ability with their follow-up staff or their follow-up program to help in maybe connecting families to financial services, helping find transportation to make visits, or even in some cases, they may help provide the genetic counseling as well. Next slide, please. So what does this notification and follow-up process look like in action? Dr. Wasserstein mentioned all newborn screening programs do strive to have their newborn screening results available by 7 days of age. Actionable or those kind of high risk or positive results are often available even earlier than that. These results are then typically called to the primary care provider on record, and program staff will try to provide some specific disease information at that time, which I'll talk about a bit later, actually on the next slide. They'll also provide directions on which specialists are available for consult and referral. Generally speaking, most newborn screening program staff do not contact the family directly, but will ask that either the primary care provider or specialist make that contact, and then together work with the family to initiate next steps in the diagnostic process. So next slide. Thank you. So for the remainder of my time, I want to quickly try to put this process into the context of what might be needed for an MLD newborn screening program. And as I mentioned on the previous slide, newborn screening programs rely very heavily on what we call just-in-time information for primary care providers. Most primary care providers will have never heard of MLD nor managed a child with MLD. So they often do need some quick information about the disease, and I think more importantly, what they need to do next. So I put some just examples of the fact sheets we created while I was in the Minnesota Newborn Screening Program. But again, each state has their own sheets, or they may use the American College of Medical Genetics have fact sheets kind of at a national level for this purpose as well. For the second bullet, I really want to highlight how important it is for newborn screening programs to really start thinking about how they can provide more supportive information to families, especially when they're getting this news for the first time. Telling a family not to Google it has, I think, a success rate of probably around 0%. So instead, having resources for the family to go to or to provide them is significantly more effective. And here I really want to point out that it's important to understand how different these families are from those families that come into care clinically after seeing symptoms in their child. These newborn screening families truly believe their child to be healthy in many cases. They've been discharged home from the hospital. They're ready to start this new adventure. And so the shock and confusion that comes from this notification is very real, and something that we have to really think through in how to best support these families. From the newborn screening perspective, they also need to understand who in their area is available to diagnose, treat, and manage these patients. In some cases, again, programs do set up contracts with these specialists to kind of ensure that these connections get made. I do think for MLD, I would think they would largely be able to use any existing contracts that have been set up for the purpose of screening for ALD as well. Next slide, please. Thank you. So another big component for follow-up, and Dr. Wasserstein alluded to this as well, is understanding what the recommendations will be for diagnostic evaluation, monitoring, and treatment of newborns identified through screening. The newborn screening community really relies heavily on the expertise of specialists and specialty organizations in publishing these clinical care guidelines to really help them build the framework and processes, algorithms for ensuring appropriate follow-up for all newborns in their state, really regardless of where those children may live in their state or what insurance they may or may not have. So I have two examples here, again, from ALD. These have been really instrumental in helping newborn screening programs and clinicians understand what should be done for these newborns and their families. You can see Dr. Wasserstein's name here. So this is a really key component, and it's so great to see that this is something that ScreenPlus will be tackling. This will help newborn screening programs significantly. Next slide. Oh, back, thank you. So I also want to quickly point out a few additional components that newborn screening programs often think through as we add new disorders. The first really centers around that communication piece and understanding that often, unfortunately, when families are notified of a positive result, they are often coming in with no to very little context. Many parents do not remember that the screening even happened or what the purpose of it was. And we've heard time and time again that families really need to be better supported during this initial notification and this initial diagnostic process, that they really want to be given as up-to-date information as possible, and really what one family coined, and I love this term, evidence-based hope for their child. We also must understand that diseases like MLD have a spectrum, and that we may pick up disease or disease types that won't manifest for years. And we really need to think through how we're going to walk with parents through this reality. And then finally, when we decide to add a screen to a newborn screening panel, and we mandate that screen, it really becomes, at least in my opinion, our responsibility to ensure that any child detected can access treatments. And we also must understand that these diseases are lifelong and require robust care coordination. This last piece in particular, this idea of accessibility and responsibility for care coordination, what Dr. Wasserstein referred to as long-term follow-up is really becoming more of a focus within the newborn screening community. Lots of discussions though, and where that responsibility lies exactly, whether it's public health, the medical system, or both, is still a bit up in the air at this time. Next slide. So to wrap up, I like to show this slide to help everyone kind of understand that the pathway to adding a disorder in a newborn screening program is quite complex. And I hope this in some way, to some extent, helps explain why even after RUSP approval, it can take months to years for a program to begin screening. In the interest of time, I certainly won't go through all of these steps, but am more than happy to talk with anyone after further about what this process looks like and where the advocacy community may be able to help programs in their implementation. Next slide. So finally, just like I started my talk, I want to end it with this visual that shows all of the various newborn screening stakeholders that represent a number of different very important areas, and really reiterate how all of these must continue to work together to move newborn screening forward and continue to improve upon the existing system, and really always with our kind of primary stakeholder in mind, which is of course the family in the middle there. So next slide. Perfect. So with that, thank you so much, and I am very much looking forward to the Q&A in a bit.
Thank you, Amy. Thank you so much. This was an excellent overview. Next speaker will be Shanna Quimby from Cure MLD, Gavin Fighting for Cure. Looking forward to your story, Shanna. The floor is yours.
Thank you. I'm looking forward to telling it. So I think I'm going to need you to do my screens for me. Thank you. Next screen. I just wanted to do a quick introduction of myself. I am first and foremost, obviously, Gavin's mom. I'm co-founder of the Gavin Flying for a Cure organization that my husband and I started when he was diagnosed with MLD. I'm part of the newborn screening task force through Cure MLD also. And my husband and I, with a lot of help, passed the Super Gav Act in 2017. I am very excited to show this video that the Leukodystrophy Newborn Screening Action Network had made to bring awareness to newborn screening. And we just want everybody to know that with newborn screening, there is help and successful treatment for these genetic disorders like leukodystrophy. And it's a very realistic possibility that these kids can get successful treatment. Here are the three moms that we worked with. Natasha, whose son Keenan died of Krabbe disease in 2018. Suzanne, whose son Patrick is currently living his best life with X-linked ALD as he was caught early as a baby. And my son Gavin, who died of MLD in 2015.
Was sweet, he was kind, he was friends with everybody, and he was so brave during his whole thing with MLD. And
Keenan means bright eyes, and if you saw a picture of him, you would know that we chose that name well.
Gavin was the funniest kid. He was sweet, he was kind, he was friends with everybody, and he was so brave during his whole thing with MLD and being transplanted, and he just was a big inspiration to everybody.
Patrick was born in 2014. and he's our third, he's our second son. And unbeknownst to us, they had just added ALD on the newborn screen that January, and Patrick was born March 12th. And 2 weeks after he was born, I got a phone call from the pediatrician saying that something had come up abnormal on the newborn screen.
He was diagnosed when he was 3 with leukodystrophy.
Of course, when he was diagnosed, again, I wasn't thinking in terms of newborn screening. It wasn't until a couple months after his diagnosis that the parent coordinator at Hunters Hope reached out to me and let me know that Illinois had passed a law in 2007 saying that they would start screening for Krabbe disease as part of their newborn screening panel. Leukodystrophies are a neurological disease, so they affect every part of the body, but it all starts in the brain.
We had noticed that there were some weird things about him, like he wasn't jumping and he wasn't climbing stairs the ways other kids his age were.
They have gained abilities like walking and talking and eating, and they lose them. They're not able to walk, they're not able to talk or see or hear or eat. The benefits of early detection is just the difference between life and death and severe disability.
The big benefit of newborn screening is effective treatment right away.
For Krabbe disease, symptoms begin in the 3rd trimester. They begin in utero.
The faster that you know about it, the better treatment you will get for your child.
So it's very important, critical to identify that child at birth, and it's critical to get them transplanted before the first 30 days of life. If you even delay that by a week, there are significant gaps in outcomes.
With ALD, if you don't know by the time symptoms arise and you figure out what's going on with your son, the damage to the brain is too significant.
Had everything gone the way everybody hoped to at the time, Keenan would have been identified at birth, and we would have had a whole different set of options in front of us. I guarantee we would have chose to transplant. Just speak your story, speak your truth over and over again.
Talk to as many people as you can. Bother them, call them, email them.
We're not going to get leukodystrophy on the newborn screen without many people from many states.
It definitely seems that the parent voice is the only way to really start the ball rolling.
When I spoke with Senator Miller, he was very open to it, and we talked to the newborn screening committee. It's just time and talking to the people that you need to talk to, lobbying for what you want, just being tenacious and just going for what you know is right and selling your story.
I remember the first time I had to get on the phone call with the staff in the Department of Public Health. I was very intimidated, but my job was to make them feel as guilty as I possibly could. That was really my task, and my son's story was the key to that.
I would love to see all leukodystrophies be on every newborn screening panel.
If we could save just one child from the suffering of a leukodystrophy, then it would be worth it. The future is hopeful for leukodystrophies.
I just wanted to add a little bit. In Illinois, where Natasha lives, they passed a legislation for Krabbe in 2007, but it took 10 years for it to go into effect. And 5 children lost their opportunity for better life. And all those children eventually did die of Krabbe disease. If the Chicago Tribune had not run that story of Keenan, it would have taken longer, which is why it's so important to just really keep on people and be annoying and bother them as much as possible to get what you need. Next screen. Thank you. I just wanted to do a little bit of story about Gavin's background. The video did a lot of it too, but I'll just kind of go in. He was born February 22nd, 2010 to my husband and I and his big sister, Allie. He was born healthy and normal. He grew into a cheerful, sweet, and lovable kid. He loved Superman and Mickey Mouse and Minions. And he especially loved watching his big sister get into trouble. And he loved hugs. We noticed at age 1, he wasn't walking. We were kind of comparing him to his big sister, and he wasn't walking the way that he should have been. He was still walking assisted with a little walker, and his left foot was kind of falling behind and he limped. So we brought him to a podiatrist thinking it was his feet. And he said that it's probably fine to bring him back in a few more months if nothing was happening. And a month later, he started walking and running and was completely normal until he was about the age of 3. And his daycare mom said to us, I think there's something wrong with him. He's not keeping up with his peers. He can't really climb stairs. He can't jump. And we were like, he's fine. It's going to be okay, like any parents would. And she's like, no, his walking is really unsteady. So we went to see a physical therapist, and she said he was fine. His muscles were just floppy and that we needed to play with him more. And as parents, we believed her, and we just let him continue on until one day he fell and sprained his ankle. And we brought him to a pediatric orthopedic surgeon, and he said, I don't think this is muscular. I think this is neurological. So I'm going to refer you to a neurologist. And we got an MRI scheduled. Next slide. Thank you. So I just wanted to show a timeline of what we went through with Gavin's diagnosis. And we had his first MRI scheduled December 20th, 2013. And the doctor initially said, I think that he might have something called metachromatic leukodystrophy. I can't be positive. I can't tell you for sure. So we're going to have to go through a genetic counselor and genetic doctor. And the hospital that we were at, I was not very, had not done a lot of leukodystrophy. So I think they were a little lost and we had no idea what was going on. So we just were like, okay, well, just do what you need to do. So we had our first ARSA blood sample in January of 2014, and that came back inconclusive. So they did another one in February, and that came back inconclusive. So they did a third one in March, and that one said, I feel like this might be MLD. Please do genetic testing for this child. And that was already 3 months past our first one, and they did it. And it came back in May of 2014 saying that he definitely had MLD. And we were like, well, now what do we do? And they're like, we don't know what to do here. So we're going to send you to the University of Minnesota. And we had all of our appointments there throughout July. And they said, yes, you should definitely have a stem cell transplant. Next slide, please. Thank you. So Gavin was admitted to the University of Minnesota Masonic Children's Hospital in August of 2014 and received his stem cell transplant to slow the progression of his MLD. He transplanted beautifully, but while he was in the hospital, he was exposed to a respiratory virus that caused him to have graft versus host in his lungs and then destroyed all the new cells that he was just beginning to grow. And because of this, he was diagnosed with another disease that would slowly kill him called bronchial obliterance syndrome. Gavin was the strongest kid and kept a smile on his face all through treatment, which is why we called him Super Gav, also because he loved Superman. This was a long process. It was about a year, and he eventually died September 8th, 2015 of MLD and the graft versus host disease. The treatment that was supposed to save his life ultimately took his life. We knew that the stem cell treatment did have its risks, but we never really thought it would happen to him. And Gavin was 5 when he died. And I firmly believe that if we had caught Gavin's MLD earlier, even just a year earlier, he would have been eligible for the gene therapy in Milan or other treatments that were happening at that time. It would have been safer for us, and he would probably still be here with us right now. Next slide. So this is where my husband and I became very big advocates with the newborn screening. During the time that Gavin was sick, I was chatting with Maria Kafalis on a regular basis, and she was subjected to my anger and rage and frustration about, like, why is this happening and what can we do? Why wasn't this caught earlier? Why isn't there newborn screening for this? And she said, well, why don't you do it? And I was like, what? She goes, well, you know, I can get you in touch with some people at Hunter's Hope. They just passed something in New York State for Krabbe newborn screening, and we said, let's do it. So we got a hold of some people with Senator Jeremy Miller, who just happened to be our neighbor down the street, and the Minnesota Department of Health, and the wonderful Amy Gaviglio. And with all of us, we eventually passed the Super Gav Act. Jeremy introduced 7 disorders for the bill, but 3 of them passed: X-linked ALD, Pompe, and Hurler syndrome, or MPS 1. Gavin, while we were working on this, Gavin eventually died, and we just kept working on it for his memory, and it kept us going, and we just wanted to help other kids just like him so that he didn't die for any reason and other babies could be saved. Also, next slide. Because of the Super Gav Act and the 3 new disorders that were added, we found 12 babies that had ALD, and because of this, the Leukodystrophy Center at the U of M grew, and here we are with Dr. Orchard, who also treated Gavin, and Dr. Lund. As of 12/29/20, 5 cerebral X-linked ALD children have been found, and 19 type pending X-ALD children have been found in Minnesota. This is in the corner. There's a family that that's their baby Callaway that we met when we passed this in 2017. Next slide. And then also, because of the Super Gav Act, there is a new foundation formed in Minnesota of June of 2020, X Out ALD. And this foundation consists of many families whose sons were diagnosed with ALD, and they're coming together to raise money for leukodystrophy research at the U of M, and also just to support each other, which is so important during this. And these little boys are the reason that my husband and I passed this bill. They'll be able to grow up, have beautiful lives, and live on through Gavin's legacy. Next. So the next steps for us in Minnesota, I'm working with Stacy Pike of Krabbe Connect, who is working on putting a nomination in for Krabbe for the newborn screening panel, and is looking for state support. And Erica Barnes of Chloe Spite and I are also working together to put a nomination for MLD. We're just 3 Minnesota moms working together to make leukodystrophy no longer a death sentence for our children. Thank you.
Thank you so much, Shanna. This is so important, sharing these kind of stories. And thank you also for all the work you have done.
You're welcome.
So with this, we will start a moderated session. And please, audience, don't hesitate to jot down some questions, because we also have half an hour to answer questions from the audience. And let's start with the moderated questions. So the first set of questions is more about lessons learned. So New York State and other states have a long experience with screening. And New York State is probably the most progressive program in the world. Now we have ScreenPlus initiative, which is super cool and super important. Because it can potentially, as Shanna already mentioned, dramatically change the life perspective for the various patients and the families, because early intervention is so crucial in these diseases. So what are the takeaways? And this question first for Melissa, and later for the other ones, what are the various takeaways from newborn screening from ALD, Krabbe, and other rare diseases that influence how you approach MLD newborn screening? Melissa.
That's a great question. So I think when we started in New York screening for Krabbe disease, it was surprising how many false positives we had. And we were really trying to figure out how to approach those kids, how to make sure that we didn't miss anybody who needed urgent treatment, but also that we didn't treat anybody who didn't need urgent treatment. So that was a big piece of why we went ahead and started to do ScreenPlus, because we figured, you know, with the experience with Krabbe, it was almost like we were learning as we were going. Mm-hmm. And in my opinion, as somebody who does a lot of research, it seemed a little bit researchy. So that was kind of why we wanted to have people going into ScreenPlus, knowing that these are new disorders that we're adding, and we are definitely still learning about the best way to approach and what the incidence is and how many have earlier onset versus later onset, but parents going in knowing what they're getting into, being educated about it. So that was one big piece. Another big piece was realizing that even when disorders are approved, maybe even added onto the RUS, it's often very challenging for states to pick them up because there's so much to learn. So we figured with ScreenPlus, if we do a lot of that background work, because we can, as you mentioned, New York is, the newborn screening lab in particular is really quite outstanding. If we do that background work and then we can just provide it to the other states as they're thinking of implementing, it'll just make life a lot easier for them. It'll be more efficient and can streamline things and hopefully can get things added on quicker so that everybody doesn't have to reinvent the wheel.
Okay, thanks, Melissa. Ms. Amy, do you have anything to add here?
Yeah, no, I think Melissa hit the nail on the head. A lot of times when we start screening, we think of it as the iceberg effect. You know, we know the little tip of the iceberg, and then we start screening and we uncover what's below the surface. And so to have ScreenPlus do some of that for us, I think will be really helpful. I think in terms of things that we've learned from screening for other disorders, again, I still go back to how we need to figure out a way to better support these families when they're getting this notification, and in between that time of, you know, you're told you have a positive result and the time you actually get to go see a specialist. I think that's an area where we can really improve upon understanding again how to monitor some of these patients that won't have symptoms for quite some time. That's a bit of a new thing for us in newborn screening. We're used to kind of having symptoms or needing treatment right away. And then finally, yeah, I think it'll be interesting for us to learn from, I guess, the SMA experience. It's our only disorder that requires gene therapy right now. And so how has that been going, both from an accessibility standpoint as well as an outcome standpoint?
Mm-hmm. Okay, thank you. Shanna, do you have anything to add from a family, let's say, perspective?
Yeah, I guess I only have the perspective of a parent who's gotten the information just far too late. So I think I would have given anything to have somebody tell me, you know, there's something wrong with your baby. It doesn't look like there's anything wrong, but, you know, in 3 years, you're going to notice this stuff happening. We're going to make sure that's not going to happen to you. We're going to make sure that your baby has a long life or a better life than what could happen. I understand like how it can be terrifying to hear that about your child, especially if you just brought them home. And, you know, like Amy said, this is a new journey, but it's terrible when the journey isn't allowed to happen for you because you got the information far too late. Mm-hmm. So.
Okay, thank you, Shanna. So Amy, also about lessons learned, what are some examples of things that have worked and not worked during the follow-up process? So some examples.
Yeah, that's a good, really good question. I think in terms of things that work well, when the program really works with specialists and does a good amount of education to the primary care providers in their state, so that everyone is a bit prepared should this happen. So I think setting the groundwork and making sure people know this is a possibility, it tends to make the process go more smoothly. Certainly, those programs that put a lot of time in thinking through what information is going to be provided to the provider and family, I think that goes well. That tends to go well. I do think sometimes in terms of things that maybe haven't worked, and I feel like a broken record, but we just hear it so often from families that sometimes they're just the way that Shanna just explained how to have that conversation with a new family to say, here's what we're going to do, and there is hope, and here's how we're going to deal with this together, that those words often don't get said. And so I think, again, trying to figure out a way to better provide this high anxiety news to families, continuing to refine that timing process so that parents don't have that gap between hearing about it and meeting with a specialist or someone who really knows quite a bit about the disease. So I certainly think that there are things we can improve upon, but I also think we absolutely can do it. They're not insurmountable issues by any means. We just need to put the time into it.
And how important are the various patient advocacy groups in this? So what is their role? How can they help here?
Yeah, no, I think this is absolutely a key place where they can help, and it can span the gamut in creating materials for provider or for programs to use that do provide some of this information. Having an area where families can reach out and talk to someone who's gone through this. So I think in this space, there is a huge role for advocacy organizations to either, and I saw Dean asked this question already, working with the newborn screening programs to figure out the best time to, I don't want to say make a referral, but let people know about the advocacy organizations as well. So I think there's a lot to be done in this area to provide that support and that real life experience of what it was like to go through it. We cannot give that. Only the parent advocacy groups can give that.
Mm-hmm. Thank you. So I have a similar question about the role of the various patient advocacy group, but it's in a little bit different context later on. So we will, let's say, touch on that later again. So the second set of questions is about referral and follow-up. So Amy, you already discussed a lot, but I think it's good to have some more, let's say, time to discuss this here. So what does the referral, let's say, pattern look like after someone is picked up? I know you already touched on it a little bit, but maybe you can explain a little bit more.
Yeah, I will do my best, and certainly will also ask Dr. Wasserstein to weigh in as the receipt of many of these. I think sometimes it can be hard to talk to this point because each state does do it a little bit differently. So if there's one thing I can encourage each parent is to work with your newborn screening program to learn what their process is and see how you can help ensure that it works well for MLD. Typically speaking, most programs will contact the primary care provider on record, which is provided to us on the newborn screening card. We do work really hard to try to make sure that that is the correct primary care provider, because often it may not be. But so we'll contact the primary care provider. We'll again let them know that we have this result from one of their patients and that they need to one, let the family know, but also connect with a specialist. And so typically we will provide a list of specialists that they can contact. In terms of who they end up contacting, I think this is also an area that could potentially use some improvement as well. Knowing if there are specialists in the state that really, where everyone should be driven to, versus kind of any type of specialty centers. So who they choose will vary state to state. Some have contracts with specific centers and they'll go there. Other states really leave it to the primary care provider and the family, kind of based on geography, insurance, etc. From there, they should fairly quickly get an appointment with the specialist, and then the specialist will really take it from there. Some have their genetic counselors reach out first, some have the specialist will reach out first as well. So it really is a bit of a mixed bag of how it works. But Melissa, if you want to weigh in on your experience or what you think works well or doesn't work well, please.
Please, Melissa.
Yeah, well, I have the experience in New York only. I spent, again, a couple of almost decades receiving babies from routine newborn screening outside of ScreenPlus, which is the research project. And as you mentioned, Amy, I think it's a terrifying phone call for parents to receive from somebody that they've never met before. You have a new baby at home, you pick up the phone and it's somebody saying, hello, I'm calling from so-and-so medical center. You don't know me, but your baby had an abnormal newborn screen. So what we do try to do to temper that call a little bit is, as you mentioned, having the pediatrician call first so that the families have a familiar voice there. And then we get them in, and we get them in right away. And there's a lot of counseling and education. My experience is sometimes that parents are just so terrified. They hear one sentence, something's wrong with my baby, and often don't get a lot of that information put in, which is where we really need help from those advocacy groups. They definitely want to reach out. They definitely want to talk to other families, and we always encourage that. I've taken a lot of my life lessons from newborn screening and applied it to ScreenPlus. So we have a very active community advisory board as part of ScreenPlus. So if we have a baby coming in, we will, besides the medical counseling and the genetic counseling, they will have resources to speak with other families who have gone through similar things, whether it's a true positive or an uncertain. We will be able to help those families through those procedures. And that long-term follow-up and how frequently, plans are good, families, something firm to hold on to for the family, to know that you're not in this alone. We're here holding your hand. We're going through with you every step of the way, and we have a plan about what to do. I think is also a bit reassuring to them that we're trying to learn and make it as good as we can.
Thank you, Melissa. So you mentioned education, and yes, education for the families is crucial. But what about education? So how will the centers be educated? Because it's a rare disease, it's an ultra rare disease, MLD, but also the other ones. And I think some of the, let's say, providers have never seen these, let's say, various diagnoses. So how will the centers be educated?
Oh, so if we're talking
providers.
So if we're talking about routine newborn screening in New York, when we added new disorders on, like Krabbe disease and exadrenal leukodystrophy, for example, we had actually all of the newborn screening referral sites participated in developing the guidelines.
Mm-hmm.
So they were all active participants in how to approach these babies, what tests to do, how to educate, given education materials to share with the families, and very unique state-run programs that I think many of the states didn't do, but I think that ensured that our practitioners or healthcare providers had that background education that you're mentioning, JJ, because a lot of these disorders are so rare that even as medical geneticists who are used to dealing with these zebras, we still haven't really seen them. For ScreenPlus, we're doing something a little bit different, where we're actually certainly interacting with all of our providers across the state, but we're actually creating materials for them, guidelines. I mentioned we have our expert advisory boards, and we're going to be sharing those guidelines with everybody. The community advisory board are also preparing, I think Maria just sent me one that they're helping out with for MLD, that we're going to be sharing with the practitioners to share with the families. So it's again a research program, so we can organize it and as much as we want, which is what we're doing. But hopefully it'll be helpful if MLD expands into other states. They absolutely can use our materials.
Okay, thank you so much. So Amy and Shanna, do you have anything to add here about educating centers?
Yeah, I just wanted to say it is so important to be referred to the correct provider. We were wasting like 5 to 6 months just being in a hospital that was, you know, they weren't comfortable with what Gavin had. They weren't sure, and I just wish that they had sent it to us right away, sent us to the U of M right away, so we could have had the correct doctors that knew the leukodystrophy as well as they did. So the correct provider. And then also, I do believe that the U of M has pamphlets for Cure MLD and X Out ALD for when those ALD children come in, and they can get a hold of the people that they need to talk to right away.
Thanks.
I agree. I think the specialist, the model that Melissa alluded to is, and I think many programs do this when they're starting a new disorder, is to bring all of the specialty centers together and say, what is this going to look like? What is the plan? And it's also a good time to have that candid conversation of, can you see these kids? Do you feel comfortable seeing these kids, or should we be sending them to a Center for Excellence or something? I also think it's important to be cognizant of the specialty centers around your state as well. I'm in Minnesota. It's not uncommon for some patients to go to Wisconsin or the Dakotas. So making sure that those providers are involved as well is really important. The primary care providers is a bit of a bigger beast because there's so many more of them. And so that's why, again, I think we do try to do some grand rounds. We often try to use the American Association of Pediatrics to put some information out, but that's then where we really rely on that just-in-time information.
Mm-hmm. Yeah, I can imagine that to reach all the primary care providers, that's a big beast too. Yeah. So going a little bit further, a little deeper, Melissa, with these ultra rare diagnoses, I think a lot of families also have questions about treatment recommendations. Will there be clear treatment hierarchy recommendations?
That's a great question. So it kind of depends on what's available at the time. You know, we know for MLD there are clinical trial opportunities with intrathecal ERT as well as gene therapy trials, and I guess it will depend on what's open and available at the time that each baby is born, because they might be a moving target as we're screening. And of course, there's always the possibility of bone marrow transplant. I think that what we'll probably end up doing when we get our first baby who truly needs treatment is we will absolutely be getting input from our expert advisors, probably having the children seen by the advisors to get input from them as to what the optimal treatment might be for that baby, given their age, given the status of what's available, you know, and what the criteria might be for trial. So it's not a clear cut for MLD, especially with the current status of treatment and trials. It's not a one and done. It's going to be a lot of discussion and a lot of expert input. Of course, along with the families I'm sure will be reaching out to other families to get their input. But it's something that we're going to have to guide along, you know, quickly, so we don't lose time as we're making those decisions.
Mm-hmm. And I realize it's challenging, and because there are multiple treatment options, and I think in rare diseases like MLD, there are nowadays a lot of clinical trials open, and but I'm also asking because there may be FDA approved treatments available. So will that be considered in the hierarchy? So if the gene therapy product, which is an EMA approved product now, and hopefully soon here at in the US as well, will that guide the treatment recommendations?
You know, I think more clinicians and more families would be, comfortable with something that went through the rigors of FDA approval. So that probably would be taken into account, but of course it depends on the type of MLD that they have. If it's appropriate for that form, or if there's something more urgent that might need an earlier treatment, it'll be taken on a case-by-case basis for sure. This is not a one-size-fits-all by any stretch of the imagination, especially for MLD.
Amy, Shanna first.
Yeah, I guess that's the beauty of newborn screening is you have all those opportunities for all these treatments and all the clinical trials, like you have somebody there telling you like, we got this early, so here's what we can do for you. You could do this or this or this. And that's what's great about it, is you have all the opportunity to get what you feel like would be good for you and your child, and what your provider feels like would be good for your child also.
Yeah, I don't have a lot more to add. I think Melissa and Shanna just killed it with the answers.
Okay, thank you all to get some clarity here. So after diagnosis, with or without intervention, because there is, as mentioned, when it's a more attenuated, but still, of course, disastrous diagnosis, but when it's more likely to be a late juvenile or an adult form onset MLD. So what's the thoughts and what's the plan with regards to a standardized, maybe centralized follow-up? Because again, it's a rare disease, and we can learn from, let's say, talking the same language and using the same endpoints and using the same measures. You already showed a little bit, Melissa, so can you explain a little more?
Well, I think, when we, like I mentioned before, did Krabbe and XALD, it was really helpful to have guidelines. I think that they are also a moving target, and we always were refreshing them every 6 months to see if anything has changed, and that's very important. I think with something so rare, I think Amy had used the word centers of excellence. It would be ideal if every baby born that is suspected to have MLD could be seen by centers of excellence. I know that all the people we've spoken with are more than willing to see all these babies, but in reality, there are families that are not going to be able to travel for whatever reasons. So we have to be prepared, and which is why we have these guidelines that are being laid out so that families, especially families that can't leave Brooklyn or wherever they might be, they will still have access to similar care.
And is there a plan? Because that's fair, because for some of them it may be more complicated to travel to New York City and come over for all these exams. Is there also a plan to try to collect from these centers to follow up, so that you can also analyze in retrospect?
Yeah, long-term data capture after newborn screening is key. We had all mentioned, I think everybody was discussing how to determine if somebody really is affected, what phenotype they have, how to learn about the different variants that we might find in the MLD gene and what they mean in terms of disease, yes or no, and age of onset, et cetera. And the only way we can really capture that data and learn from it is if we are very meticulous about following up and entering that data in a database and then studying it and learning from it. So that long-term follow-up is a really important part of ScreenPlus, because we know how critical it is when you're scratching your head every single time you get a new baby, but you learn each time you go forward. And this is not just for MLD, but most newborn screening disorders do have these efforts to try to capture this data, whether it's on a national level through the Newborn Screening Translational Research Network. Some states are having their own long-term follow-up programs. Again, ScreenPlus is research. It's much easier to manage and to organize it. But yeah, it's a key piece of this. We also want to learn what a pre-symptomatic baby looks like. Most of our MLD community, the babies were diagnosed because they have symptoms. We want to know, what is the earliest thing that we'll see? When do we need to treat? Is there something that we'll find in the blood marker? Is there a sulfatide increase? Is there something that will guide us? That's all really important. And that expands beyond newborn screening to babies who are born in states without newborn screening. That might be, if a physician sees a strange sign, they might be able to look it up and see that we published something that this particular sign might be MLD, and maybe we can help another baby even if they didn't benefit from our program.
Thanks. So you are, let's say, mentioning early markers for initiating disease or start of disease. So is there also let's say correlative study doing biomarker research to make sure that you can predict the onset of disease in an early phase? And I think, let's say, maybe more important for the little bit more attenuated forms. So are there also correlative studies related to the ScreenPlus?
I don't know if there's anybody that's looking for additional biomarkers for MLD. Right now we know sulfatides, and as part of those follow-ups, especially for the babies who don't have any symptoms, and we'll be watching them like hawks to see if they develop anything, we will be monitoring sulfatides. But I don't know if there are other biomarkers. If there are others that we learn about, we will probably incorporate those into that screening process.
And is there an effort to, or a joint effort to combine and data with the Europeans?
We haven't gotten that far yet. I think we had spoken a while ago when we were on our expert advisory call about sharing data with some of the existing MLD leukodystrophy data sets, because if we get a few children coming from ScreenPlus, it's not a whole lot of data. If you guys have a lot more, we'll be able to make a lot more sense out of it. So I'm a big fan of sharing and collaborating, and I think that with these rare disease databases, it's historically always been a monumental challenge because everybody makes their own and industries make their own, et cetera. But to try to coordinate and collaborate and have one bigger database that can capture most of that material is just beneficial to everybody.
Yeah. Okay, thanks, Melissa. Shanna, Amy, anything to add here?
I just wanted to, this is complicated for everybody. It's research. I feel like this is why family advocates are so important, why there's so many organizations just to help the parents get through all of this while, the providers are doing the research and finding the information that they need for their baby. Every day is a battle for them just to get through it. So I just wanted to say that that's why advocacies are so important, just to help get through for everybody involved.
Yeah, totally agree, Shanna. Thank you.
Yeah, no, I think the first thing to say is that we haven't done a good job with long-term data capture for any of our newborn screening conditions, including the ones we've been screening for 50 plus years. So I don't know that there's a great model out there, but it is something that the community is thinking more about. And I think it's also important for us to think about, what do we need from a public health surveillance perspective in terms of who have we picked up? What does their access to care look like? Are we doing what we said we were going to do when we started screening? Are we improving outcomes versus all of the very appropriate clinical questions that you may ask in a registry as well? So I do think this is something that we need to work more on and try to figure out how to do this at a national level, getting robust data, but also not burdening all of the specialists and entering all of this data. So I think we need to start leveraging some existing technologies within the public health space that allows for more automatic data capture so that we can kind of do this more robustly and more often as well.
Yeah. Thanks, Amy. So Shanna, coming back to you about staying connected and keep the families connected. Because it's a continuous education, because we're going to learn from the programs, the ScreenPlus, from the database. How do you envision to make sure that the family stays connected? Also, for instance, there can be residual disease after an intervention, after gene therapy, after BMT. So yes, the phenotype has changed. So the kid is doing better.
Yeah.
So
yeah, so I am on I've talked to a lot of people through a lot of advocacy groups, and people just stick together. People talk. I've become great friends with other people through other groups, and, you know, they become your family and your good friends. You just kind of keep them together. And I know, like, a lot of people will message. You're just thinking about, like, how to keep in touch. Is that what you're asking?
Yeah. And how to make sure that because it's a continuing education and it's changing over time. So let's say perspectives may change, and how do you make sure that everyone gets the appropriate info?
Yeah, I think that a lot of people take that upon themselves to find the group that they want to, because they need information and they just want to get it from a parent's perspective. And a lot of those people still keep in touch, even after the gene therapy, even after bone marrow transplants or stem cell transplants. It's the whole leukodystrophy group is huge. It's worldwide, and we find each other and we help each other through everything.
Yeah.
Whether we're just messaging them every once in a while, like, hey, how are you doing? How are things going? People post stuff on Facebook so we can keep up with what's going on with them that way also. Somehow we just find each other and help each other through all of it.
And that's so super important.
Great.
Particularly now we are going to see also long-term follow-up in the patients who got gene therapy, in the patients who got BMT. And also learn that it's still not the holy grail, because they still, some of them still face issues, even after intervening.
Yeah. And they know they can reach out to any of us at any time and talk about stuff. I've bothered so many people, like before Gavin had his stem cell transplant, and I still talk to those people today, even though he died, and I keep up with their kids and how they're doing. So it's like a big family.
Yeah. Thanks, Shanna. So the last couple of questions before we go to the Q&A from the audience is about expanding screening. So Melissa, New York State is now the only state having MLD in the newborn screen pilot. When might we expect to see MLD newborn screening throughout the US? What needs to be done and before this is going to happen?
That's a good question, and I'm not going to be able to give you an exact answer, of course.
No.
What I think is going to be important is to have treatment options. I think it's going to be important to have an established screening assay that can be implemented in other states. The screening for MLD is a little different than for some other disorders on newborn screen. And then, of course, I think, you know, a RUSP application and a RUSP approval is always key. And for those who don't know, the RUSP is the Recommended Uniform Screening Panel. And it is a panel of disorders that are recommended for uniform screening that have gone through extensive data review about how newborn screening works and how effective it is and what the treatment options are. If something makes it to the RUSP, then most states do adopt it eventually. To get something on the RUSP, though, does require a village. I'm happy to supply the data that can be used for the RUSP application, and hopefully that will help push things along. But I think that those things are going to be important before other states start adapting MLD, because most states, you know, honestly are already a little bit swamped by new disorders that they are on the RUSP, but they still haven't implemented because they don't have the budget or the personnel or whatever. So it's a big effort to get them expanded.
Sure. And so can you give a realistic timeline to get it on the RUSP?
You know, we're going to be screening for 5 years once we start, so probably 5 years until 2026. If there are approved treatments, and if the FDA approves the treatment that was just approved in Europe, then that will probably push things along faster. And maybe we won't have to wait for all of the ScreenPlus data to come out, that the RUSP application can be done long before then.
Okay, thank you, Melissa. Amy, Shanna, anything to add?
Yeah, no, go ahead, Shanna.
Oh, I was just gonna say, families just need to keep telling their stories and advocating, you know, just keep that up. That's all I can think of for that.
Yeah, I think, you know, for RUSP, you know, they're going to look at things like, you know, Mike Gelb and Joe Orsini are working hard on showing the feasibility of doing this test, not only in a research perspective, but in a high throughput newborn screening program where you're getting hundreds to thousands of samples a day. So making sure that it can be done within the structure of a public health program. I think they're very much on their way to that. Then I do agree with Melissa that the limiting factor becomes the effectiveness, availability, and accessibility of the treatment. That's always something that they look at quite a bit is what does the treatment look like? And can we show that it is making a difference? I do think the whole concept of kind of that later onset is becoming less and less of an issue as we are dealing now more with more conditions that have that, but just being aware that is a possibility, and what will that look like for those patients. The RUSP process in and of itself is quite long because of the evidence review, and I think appropriately so. When we decide that we are going to say you have to have this testing, we want to make sure that we're not taking away parent rights, you know, for just anything. But it can certainly, it's just built in. It takes some time, and then, as I mentioned, that's really just the first step from now going out to the states. But I think as more and more states show that it is feasible to do, that they can do the follow-up, it does start to have a trickle-down effect. And certainly having this pilot data from ScreenPlus is something we often don't have, and so we could see it being expedited just simply because of the work Melissa is doing.
Mm-hmm. Thank you, Amy. So I think with this, we end the moderated session, and because we have a lot of a lot of questions from the audience, I think 16 or 17. So some of them, but I would like to answer them live as well. So Dean Sur had a couple of questions. Maybe, let's say, Melissa, you answered one of them already in the chat. But the first one was for you, and I think this is an important one to answer live as well. So pre-symptomatic therapy is most effective. So why defer therapy with 4 months evaluation looking for symptoms?
Well, we're not deferring therapy for 4 months. If we have a baby who's referred, we're going to be seeing them immediately. So we have that first visit. If that baby is symptomatic, if that baby has a genotype or genetic information, DNA changes that we know are predisposing to early onset disease, boom, refer to treatment. That 4-month follow-up is for those kids who have no symptoms, who might have variants that we don't know. We're not sure if they're going to develop symptoms and when they're going to develop symptoms. So we're following them every few months. From other newborn screening programs, for every 4 months might be reasonable for parents to be coming in and out. Of course, with follow-up with the pediatrician in between, and discussions with the pediatrician and the family as to things to look out for in between those those every 4-month visits. Mm-hmm. So we simply cannot treat every baby that comes in from newborn screening, because many of those babies will be false positives, won't have disease, might not have disease for many years, and the risk of treatment right now, which would be a bone marrow, which is what's available in the US, you can't subject a baby who doesn't necessarily need that treatment to something that's so potentially invasive. So we have to be really careful, and this is why we'll be following them really closely and monitoring them, and at the first sign of anything, they'll go to treatment. So just like we had with Krabbe, like I mentioned before, we don't want to miss anybody, and we definitely don't want to treat anybody who doesn't need it.
Thanks for this explanation. I think that's clear. So if there is a suggestion, so let me summarize that. So if there is a suggestion that this is an infantile early form of MLD, we go ahead. Of course, the diagnosis needs to be confirmed. So what's the, let's say, percentage of infantile MLD, let's say, patients you expect? Isn't that majority of patients?
So we're not sure. You know, what a lot of the data for these rare diseases is published, and it often reflects certain populations.
Mm-hmm.
The MLD population data that's been published is not necessarily reflective of this diverse population that we're recruiting from. With our past pilot screen, we were actually really surprised by the disease incidence that didn't really necessarily reflect what was published. We were also really surprised by how many later onset cases we had for other types of lysosomal storage disorders. Like the vast majority were later onset, which had never been published, and we didn't expect. And we might find something like that now too, because it's likely that later onset cases are underdiagnosed. So we'll see. So it's a good question, JJ, but it's a really hard one to answer.
Yeah, agreed. Because we may have missed a lot of later onset ones because we don't know. Yeah. So Dean had a question to me, and this is about experience of transplant. So next week the session will be about therapies, but I can maybe answer quick. So what is your experience transplanting pre-symptomatic infantile MLD patients, like the ones who are going to be picked up with the newborn screening? At what age do you think they should be transplanted, and what age juvenile and adult onset ones? So that's a good question, Dean. So for the infantile, let's say, patient, and this was also the inclusion for the gene therapy trial in Milano, and I think that's for a reason. Because in the infantile MLD patients, if you are symptomatic, the outcomes are pretty poor. And Maria Escalar also, let's say, published on this, and we have published on this in Europe, in Amsterdam, Utrecht. So for the infantile form, it's really crucial to be pre-symptomatic, although also for the gene therapy. For the juvenile and for the late juvenile and for the adult onset one, and interestingly, in the Netherlands, there is more attenuated MLD, so more late juvenile and adult onset one. I think that's about 50%. So we did a fair amount of transplants in these patients, and they also, in these patients, being pre-symptomatic is better. But in the adult onset, sometimes we accepted a little bit of disease because the disease was progressing very gradually over the years, and these patients seems to do also relatively okay when you do the intervention, when there is a little bit of symptomology, so a little bit of symptoms. So in the infantile, important to intervene early, and I think gene therapy is preferred above BMT simply because you can reach higher enzyme levels. And I think the data from Milano also show that clearly, that the outcomes after gene therapy are better than after bone marrow transplant. Also speaking from my own experience transplanting pre-symptomatic infantile patients. I hope that answers your question. So the next question, also Dean, for Amy, building on your comment about parents needing support and education, what will it take to empower public health to refer directly to advocacy organizations for this support as they do clinical therapeutic care?
Yeah, no, that's a good question. I think in the past there have primarily been two components that have maybe stymied this type of direct referral approach. The first can be if there are multiple advocacy organizations, it's hard to know who to refer to or how best to accomplish that. Most public health programs don't want to be seen as endorsing any one over another. So that can be an issue at times. And I think the second issue is also just that patient privacy issue that public health often really, is important. And so to do this may involve actually establishing contracts or relationships with advocacy organizations. Again, I am not saying that this is not possible. In fact, there is precedent for this. I think often in actually the newborn hearing screening area, we do see some direct referrals to patient organizations like Hands and Voices. So I think there's precedent for it, but it probably would require some sort of formal relationship to be able to say, I'm going to give you this family's information without their consent. So I think those have been kind of the two pieces that I have experienced as being holdups. Again, I do think, working with the public health program, figuring out what their process would be, I think we could potentially get there, but those are kind of the things that I would think about as we work towards that.
Okay, thank you, Amy, for answering Dean's question. So, Maria, big shout out to you, Shanna. And the following question, Cure MLD is working on global partnerships and collaboration with the tribal health system. What sort of recommendations do you have to partner with stakeholders in the EU and other healthcare systems who are far more skeptical about newborn screening and genetic testing?
Is that for Maria? Because I feel like she could probably answer that better than I could.
No, this is for you. So this is, let's say, question from to you.
Oh, from Maria for me?
Yeah.
I think that just, I feel like Cure MLD is becoming global. And I feel like this kind of stuff that we're doing right now, I would like to see get out so that they understand that newborn screening is important. I know that a lot of parents are afraid to see the newborn screening stuff happen because they don't, like we've talked about in the past, they don't want to know that their child is sick. It's a terrifying thing. I just think that the Cure MLD is becoming more out there, that we are very involved with other people like in Brazil and in Europe, and just those people in Ireland. There's a family that is very big into newborn screening also, and just getting more families through Cure MLD to tell their stories so that it gets out farther is very important also.
Yeah, I agree with you, Shanna. I think it's so important to connect to all these organizations globally. And I already mentioned earlier, it's such a rare disease, so we should try to learn from all the continents. And honestly, I think the databases and the data in Europe, because they have a little bit more experience also with the transplant and the gene therapy over the last couple of years, I think we should try to learn from them and try to connect to them and see what we can, let's say, get out of it. And better, let's say, collaboration, fruitful collaboration also may advance the field faster. Because you need the numbers, So I'm also working in cancer, and that's maybe sadly a little less easier because there are more patients. So you have an answer, let's say, earlier. So if they are not here in the US, we have to try to go out and see whether we can connect to other networks.
And just getting ideas from them also, like how they have done that in the past is good. I like hearing from other families and what they've done from all over.
Can I say one thing to this point? It's interesting, the skeptical about newborn screening and genetic testing. I think that's true in many countries, including our own in many cases. And I wonder how much the kind of all or nothing approach of newborn screening stymies us sometimes. It's either you don't screen at all or it's mandated and it's, you know, everyone gets screening. Is there an opportunity for an in-between where it is a model more like ScreenPlus, where you offer consent and you at least get the ball rolling, you offer it to parents, you develop that robust consent process, you show that parents are interested in it, you show the value of it, and then you can move it along. So I wonder if that's an approach that you could use also in Europe. I think having that middle ground might help move us faster than we have been in the past.
I also feel like seeing children that, you know, are doing great with the newborn screening because they got treatments faster is also important for them to see, instead of seeing, you know, kids that maybe are doing as well because they caught it later on in life. So just that kind of stuff is important also.
Mm-hmm.
People telling their own stories.
Mm-hmm. So about the skepticism in some of the European countries, I'm not sure they are really skeptical, but I can speak of the situation in, let's say, the Netherlands, but that's not much different in the other European states, is that there needs to be a treatment and there needs to be a follow-up program. So for instance, MPS 1, it's in the newborn screening now in the Netherlands, but not after it was clear that bone marrow transplant was a treatment option and that the outcomes of these patients was way better than the patients who did not receive a bone marrow transplant. So it was a long process. So and before it gets approved, all the steps after also needs to be in place. So there needs to be a clear treatment program, there needs to be a clear treatment plan, there needs to be a clear referral pattern, etc. So all the steps we have discussed today needs to be in place, and then it gets approved by the, let's say, government.
Mm-hmm. That's how it was in Minnesota too. The 7 disorders that we put on the bill, the ones that didn't make it, was because there wasn't treatment for it, like good treatment for them, and nobody wants to hear that their baby's sick with something and then there was nothing to do. You know, you just have to wait for it to happen. So like you said, that's very important.
Yeah, agree. So a question or a comment for Mary. I have a daughter with adult onset MLD. She went 15 years with a mental health diagnosis. We thought finally with her symptoms, she must have a brain tumor, which is how she received an MRI. She chose transplant, which was her only option, and she did stop her progression of disease, but unfortunately did not undo the damage already done. My husband and I did not know we were the carriers of the disease, and once diagnosed, we had no idea where to go, what to do. Melissa, can you comment on this? I'm happy to comment on the transplant outcome. I think, yeah, thanks for bringing this up. And I think this also illustrates the importance of intervention therapy before there are symptoms. Because the damage that's already there is not going to heal. So if you are diagnosed either early in life or later with MLD, if the damage is already very severe, you really have to think of, is this really going to impact and change my life perspective? So the earlier the better, and again, newborn screening is going to help, hopefully, also to identify the later, the more attenuated forms, because you can follow up, and once you can see or think there's a disease onset, you can intervene. But maybe, Melissa, can you, let's say, also comment on?
Yeah, I guess the whole point of newborn screening obviously is early detection and pre-symptomatic or really early pre-symptomatic treatment. You know, I think one of the things that we're going to be learning is how well newborn screening can detect later onset phenotypes. We did that with Krabbe. We found a lot of people at risk for later onset forms. It's similar for Pompe. It was similar for some of the other lysosomal disorders. You know, the goal is really is not really to be focused on later onset. We will likely pick them up. I think we're going to learn as we go how many we actually are picking up of that later onset form. I'm suspecting that we're going to probably get most of them, which would then enable us to time treatment well before you know, the circumstance that you mentioned, hopefully before disease progresses and where we can still capture it and really change the outcome.
Yeah. Thank you, Melissa. So a question from Paul Orchard, following the onset of COVID, there was great interest in facilitating, let's say, telemedicine. It seems this may be very helpful for families with rare disorders to reach out to regional national centers without necessitating travel to a site. I'd be interested in the ideas of the families in regards to this. It seems many of the barriers that came down during the early stages of the pandemic seems to be going up again. What can the CDC, NORD, or family advocacy groups do to help keep these options open in the future? Shanna.
Well, I feel like just keep doing what we've been doing. I know COVID really put a stop, like he said, to everything that we had going before. I know that we'd had a few meetings to do the newborn screening stuff in Minnesota, and that just all got to a halt with Dr. Matern in at Mayo Clinic. I just feel like keep doing what we've been doing. Just start all over again and just keep pushing through. I know I'm working with Stacy Pike and Erica Barnes in Minnesota, and we still have plans to keep going with what we were doing before. It's hard to know when everything's going to open up again and when we're going to be able to meet in person and start all that. I just plan on keep on doing what we're doing when it's safe.
Mm-hmm.
Yeah, I do think the increase in the availability of telemedicine during COVID may be one of those COVID silver linings that we can hold on to. And Paul is right. What made that happen partially was, of course, the necessity of having to do telemedicine, but also that a lot of the barriers for reimbursement and cross-state borders came down to allow for that. And so I think certainly at the national level, we at CDC, I think AMCHIP, the American Association of Maternal and Child Health Programs, really will be working to show how valuable that was and how important it is to continue that, especially in the rare disease space where I think Melissa mentioned not everyone can travel across the country to see the specialist. So how can we bring the specialists to them in some cases when appropriate? So I do think showing the value of telemedicine, both from a medical perspective, but also from the family access perspective, will be important for us to kind of keep telemedicine going and not have us revert back to the pre-COVID days.
Thank you, Amy. I hope this answers your question, Paul. Melissa, wouldn't a low enzyme level count to be a biomarker?
That's a very interesting question, and I wish the answer was yes, because that would be a pretty easy way to go. But the answer is not yes, and the reason why is because there is something called a pseudo deficiency, and that means that people might have an RSET activity that looks low. They actually don't have MLD. And that's probably more common than people actually really having MLD. And that's actually the reason why we can't use ARSA activity or alpha-sulfatase A activity as the primary newborn screen, because we would have so many positives and the vast majority wouldn't actually have disease. So that's why we can't really be using it as that first screen. And also using it going as a biomarker to see if things are changing. It's also an interesting question, but usually enzyme activity, if it's low, it stays low. It doesn't get lower to tell us that the disease is getting worse. It doesn't get better. It just stays the same. So a biomarker is ideally something that can change as the disease changes and can let us know that the disease is changing. I hope that answers that question. It's a really interesting one.
Thanks, Melissa. I think it answers. Another question from Dean. I think this is an important one, as all the others, but I think this is about reimbursement and access. There are limited MLD experts and therapy centers. How do we address across state access and reimbursement challenges, especially when about 50% of the patients are on Medicaid, and we get screening in more states? The states, let's say public health programs, may want to limit the therapy to only what is available in their home state. I think in particularly when we get FDA approval for the gene therapy product, this could be a serious challenge. Melissa, and Amy after.
I think that once we have an FDA approved treatment, it's almost impossible for an insurance company not to approve it for a rare disease, although it can be a fight. And similarly, if we prove that bone marrow transplant is the only thing that's available, it's an effort to get it approved by and get coverage for it, but it does happen eventually. So it's a challenge, and it's a one-on-one, and everybody realizes how complicated the American medical insurance system is. I think that's where we could also probably use some help from advocacy groups, because sometimes we do need to fight the insurance company and supply letters, and it's a challenge on all parts. So I know for one of the other disorders on ScreenPlus, one of the advocacy groups actually shared their templates with us so that we can make that fight a little bit easier to make sure that our families do have access to treatment that they need. Yeah.
Thanks.
It's a big question. I do think one thing that we've seen in the newborn screening community recently, and I would say SMA really is what drove this, is that programs are starting during that implementation process, reaching out to their Medicaid within their state to discuss reimbursement. But how effective that is, I think it at least starts the conversation, but we still see families needing to use things like GoFundMe to pay for their treatment, which is absolutely heartbreaking. So I think just continuing to have those discussions and bringing those people to the table, either during implementation or as part of the advisory committee for your state newborn screening program, highly recommend having payers on there so that they can understand the impact and the importance of approving this and approving this quickly. I do think, Melissa, you're right, templates, pre-authorization templates, et cetera, can help as well. But this is an uphill battle for sure.
Shanna.
Yeah, yeah, I'm excited to answer this question. Actually, the Calliope Joy Foundation has sent families to Milan in order to get treatment, and we have raised money through runs and amazing bake sales to raise all this money for these families that don't have the money to maybe just go to the next state where to stay, and vouchers to eat, and for gas. The advocacy groups work very hard to help these other families, because we've all been there ourselves, and if we can pay it forward in any way, we will. So we're there for them, and we have the funds to help them get there. It's just finding the families and having the families find us in order for that to happen, which is the beauty of social media also. You just Google something and find it, and then within the next couple of days, someone will reach out to you and tell you what you need and what you didn't know that you needed, and that we're there for you to help you, whether it's financially or emotionally.
Mm-hmm.
So. And like they said, fundraisers is big. GoFundMe. And those families raise money themselves too. Like a lot of them will have runs for themselves, and yeah.
Thank you, Shanna. So let me see, it's 5 minutes to noon here in New York. So maybe we can do one more question. Dean, there are opportunities for treatment only if the referral process has urgency. I'm thinking about unknowns and juveniles accessing therapy early. Their treatment options are become limited after first symptoms show up in every 4 months monitoring. I think we more or less already answered this question. Yes, the earlier the better, and for the later onset forms, it's crucial to have monitoring, and once there are symptoms or when there is uncertainty about onset of disease, these patients need to be referred to a therapy center. Transplant, gene therapy, hopefully soon here, or to Milano, or other experimental interventions. I think with this, we come to the end of this meeting, and I really enjoyed it. And first of all, I would like to thank all the various panelists. I would like to thank Maria, and I would like to thank the audience for all the various questions. And we hope you found these updates in MLD Newborn Screening valuable. And please don't hesitate to reach out to Cure MLD with follow-up questions, and of course also collaborative inquiries. We also hope you are able to join the next and final session next Friday. It's March 12th at 10 a.m. entitled Updates in MLD Clinical Therapies. And I'm really looking forward to that. It's a great lineup, an update on the gene therapy outcomes, transplant, and other therapies. So with that, again, thank you so much. And I hope you have enjoyed this session. And have a good rest of your day.
You too.
Bye-bye.